This podcast is supported by our bronze partners, Icon Cancer Centre. Well, this is a rather strange episode of GUcast. First of all, I don't have Renu beside me here in the chair. And second of all, it's me and not one, but two, but three radiation oncologists, particularly specialised in prostate cancer. Andrew Loblaw, you just described yourself as the, what did you say?
One of the three horses of the apocalypse.
Okay, here I am with three horses of the apocalypse. But welcome to this episode of GUcast, which is titled "A Urologist and Three Radiation Oncologists Walk into a Podcasting Studio." What could possibly go wrong? But yes, I'm privileged to have three fantastic radiation oncologists here in the studio. Here beside me, my colleague from Peter Mac, Sarat Chander, radiation oncologist, very specialised in prostate cancer. Sarat, welcome to your first episode of GUcast. And you're in Renu's chair. That's it. You're the boss.
Thank you, Declan. It's a hot chair, I can say. It's difficult to get in.
It is. Well, she was texting me from Singapore earlier saying, Sarat's going to love it in that chair. But you've brought along two of your buddies who are here in Australia for the week, especially to speak at the FROG conference, the GU Oncology, Radiation Oncology Conference. We have Professor Vedang Murthy from Tata Memorial in Mumbai here.
Hello, everyone. Great to be here, Declan. That too in your house. Beautiful studio. Thank you so much.
Well, great. Well, thank you very much for coming along. And so I know you're heading to Brisbane later in the week, but you came to Peter Mac today and you did some teaching. And thanks for making time to come out here. And we'll take you guys out for dinner tonight with some of the team as well.
Pleasure.
Which will be great. And Andrew Loblaw, you've been around here for a few weeks. Andrew, radiation oncologist from Sunnybrook in Toronto. Andrew is on, I think, sabbatical. Is that how you describe it?
Yeah. So a 3-month sabbatical. So I'm trying to get an old dog to learn some new tricks.
Yeah. So, and look, we've had the pleasure of bumping into you here and there over the past few weeks, but thanks very much for coming into the podcast studio. It's been fun getting to know you in recent weeks here. We've known you for your reputation and social media, of course.
Some good, I hope.
Most of it good. Okay. The horsemen of the apocalypse. We'll get it. So we may have a little bit of, fisticuffs on this podcast, me trying to defend the role of urologists in prostate cancer up against these three experts. And Sarat, I'm going to pick everybody's brains on, hot topics in radiation and prostate cancer, and we've picked out a few things we'll get through. But before we do, you're kind of the glue here that brings the three of you together. Can you explain a bit what your how far you go back with Vedang and Andrew?
Yeah, so that's right. And my training was initially in India in Tata Memorial Hospital, where I did a senior residency or senior registrarship, as it was called. And as I was leaving, it was Vedang Murthy who joined as a trainee. So
that was the time I was just trying to figure out where the prostate is, actually. He's the one who taught me.
That's right. So prostate cancer was not really a thing in Mumbai at that time. Yeah. I don't remember having seen a single intact prostate treated with radiation at my time, but you treated a few metastatic disease. So obviously, a lot has changed, and we have an international figure from Tata Memorial now, obviously treating a lot of prostate cancer.
And doing some really good prospective work, I should say.
Yeah. And Drew, I met as a new consultant when I went as a fellow to Sunnybrook to learn urological cancer management and brachytherapy in particular.
The witchcraft.
Yeah.
And
the healing rays.
Drew used to guide me past. He used to guide me past the Tim Hortons and call the Timbits. Yeah, that one. He used to call it the heart attack special. Yeah, I remember that.
They're very good, but they're very bad for you. So
yeah. And that's been one of your interests since you've come back to Peter Mac after those experiences is brachytherapy, and we're going to get to that. And you still do a lot of, HDR especially rather than LDR brachy.
Yeah, that's right. So the way things have moved with active surveillance coming in, what's reimbursed in Australia has been traditionally low-risk prostate cancer for seed brachytherapy. Yep. So we're not seeing much of that. They're all going to active surveillance, and we do some favorable risk with seed brachytherapy, but mostly it's been HDR monotherapy and HDR boost. And recently been doing a lot of salvage and tricky brachytherapy.
We're going to get to that. So what we've decided to do is, we're going to focus on three sort of there's lots of topical areas in prostate cancer always, but prostate radiation. 3 particular areas. The first is going to be hypofractionation in 2025. So if you're out there listening or watching to this podcast, there's a lot of stuff coming on hypofractionation. What does that mean? Who should have it, et cetera, et cetera. How should we do it, et cetera. Number 2, who needs ADT when they're having prostate radiotherapy? Because this is, definitely something we don't like doing without good justification to say, on balance, it's going to be worth having a period of ADT. And it is a moving area. Mm-hmm. So I want to pick the brains of Sarat, Vedang, and Andrew about, the role of ADT with radiotherapy, both for primary prostate cancer and salvage. And third, then metastasis-directed therapy, the emergence of SABR, PSMA detected oligometastatic disease. What do we think about all that? Have we picked the sweet spot for who benefits most from this, or should we stop just zapping these little metastases as they keep coming up? And if we have time later on, there's a few other quick speed dating type rounds I want to pick your brains on. But first of all, Andrew, I might ask you about hypofractionation in 2025. So, one of the things that traditionally has been a deterrent for patients, I think it's fair to say, is the idea of having, 6 or 7 weeks of radiotherapy here in a country like Australia, indeed Canada and India as well. It can be an off. I haven't got time to leave the farm and spend 6 or 7 weeks having radiotherapy. So the idea of being able to deliver definitive radiotherapy in shorter doses clearly has some attraction for patients and clinicians. Lots of good data has come out. So first of all, what's your take on hypofractionation? And then
it's a revolution, really.
Revolution, wow, yeah.
So in the US, actually, some patients get treated up to 10 weeks of radiotherapy or protons, which we'll talk about. Yeah. So basically what hypofractionation means is it's a higher dose per day of radiotherapy, meaning you can concentrate the treatment into a shorter number of visits. So we have gone through 25 years of consistently shortening these doses. Brachytherapy was one of the first ones where we could shorten it. But the standard is now 5 treatments, and that's SBRT. And so it's a high precision external beam form of treatment that delivers 5 or fewer. We've actually shown that you can do it in 2.
A whole thing, treat the whole prostate, for example.
95% chance of control in 5 years, 90% at 10 years with only 2 treatments.
What dose do you get in 2?
So we divide, if you're giving 2 treatments, we give 13.5 gray in 2 treatments. So it's the equivalent of a full course of brachytherapy and external beam. So it's the equivalent of 11 weeks of conventional radiotherapy. But we can actually give it, to your point, like patients from Canada and Australia have to come in from miles and miles and miles away. So we calculated people actually from driving and parking costs alone save $3,000 out of their own pocket. And that's a nice flat screen TV.
Now, Vedang, this sounds too good to be true. And the reason why we've had a fractionation is because traditionally we've been anxious about delivering that, curative dose of radiotherapy in, biggish bursts. And I suppose that harks back to a different era when contouring was totally different, the imaging technology totally different. But is it too good to be true? I mean, is there going to be a sting in the tail down the line in terms of morbidity? That's the key question. And as Andrew says, we can see good efficacy, but do we need to still be a little bit careful about the toxicity of giving big doses in 2 or 5 fractions?
So if you're talking about moderate hypofractionation, which is moving from 7 or 8 weeks towards 4 or 5 weeks, the line is already here. I mean, we are 10 years, 15 years down the line already with the chip and other data. Yeah. Thousands of patients have been treated. So I don't think there's a sting in the tail. I think we are past the tail now. And what is past the tail is the 5 fractions. Now, there could be a sting in the tail, but I don't think it's going to be a very painful sting with the toxicity. We've been treating, I was telling Andrew, he started SBRT prostate in 2013. So did we. It's 12 years we've been doing it. Yeah. And we've published multiple patients, hundreds of patients together and individually. And there is some increase in some toxicities, but I don't think it can only be attributed to the dose per fraction. There is obviously multifactorial.
But I think it was a good point we brought up today with registrars, talking about toxicity and the difference between a medical oncologist, for example, and what we consider toxicity. We're getting very worried about, I think, what you and I believe is really inconsequential. Like prescribing an alpha blocker for someone to relieve themselves a little easier isn't really a toxicity in my mind. So you probably don't. I don't know if you think the same thing.
Yeah, I totally agree.
I'd just like to add that we've shown that hypofractionation is effective with brachytherapy, and we have that data for a long time. So it's just a transition.
A different type of technology.
In general, with SBRT, I think even long term, if we talk of serious radiotherapy related toxicities, 1 or 2%.
And I agree. And look, one of the things we surgeons always have to take our hats off and acknowledge is the quality of the prospective trials that the GU radiation oncology community consistently produce all the time. But, you know, I love a good anecdote. So let me resort to anecdotes. And we were recently in London and we did a podcast completely about radiation cystitis, because there's a unique clinic at Guy's and St. Thomas's. Every second week they run a radiation cystitis clinic led by a couple of urologists who are bladder cancer surgeons. And one of the things they said to us, Ramesh said on the podcast, is they believe that hypofractionation is a problem. You know, they are their mind is being focused. They are collecting their data, but they of course they've been living with hypofractionation for a long time in London, and he thinks there is a problem with the toxicity. Of course, they're seeing the skewed population of those patients, etc. But their sense is that. So that's why I asked the question: is there a sting in the tail? Andrew?
So there's a difference between the dose and the fractionation you give and how you give it. So I think when you give large margins with large doses per day, you're going to get into trouble. And I think that's probably historically what happened in the UK. They give very wide margins to be safe. They don't want to miss the cancer. Where we're moving, and the conversation at the end, is all about high precision, pinpoint real-time motion management. And I think as you reduce the amount of normal tissue in that high dose region, you're going to see those side effects go down.
Yeah, look, I'm personally not concerned about that. I really do truly believe it. And I think it's been probably one of the biggest advances over the last 15 years is even moderate hypofractionation, and now down to super hypofractionation, if you want to call it that, because it does make radiation a lot more attractive for some patients. So yeah, sure. Good. Now, Sarat, while we're on it, before we go on to the ADT question, and SABR was mentioned there. I know you do lots of even primary SABR, but does this render brachytherapy a bit like old technology? Because it seems a bit brutal to me. You have to go down to the operating theatre. You guys never start on time as well, but I just want to put that in there that, the complaints we get at Peter Mac about, where are they? They've wandered in, there's 15 registrars and 17 physicists and stuff, and, blah, blah, blah. We've already taken out a prostate down in Theatre 1. But do you need to do that? Do you need to be sticking cannulas in or seeds, dare I say? Or can't you just do that with non-invasive technology? You can do these beautiful high doses in 2 fractions or 5 fractions. So
there would be some situations where probably SABR is the easier way out for intermediate and low risk, but we still need some more data about high risk, I feel.
Okay, great. Yeah.
At least there is definitely a place for boost yet. Maybe monotherapy is being challenged by SABR. There are also, it's a very good skill to have, because there are situations where brachytherapy is best, like people who had previous pelvic radiation, people who have poor anatomy, like bowel stuck down in the pelvis, and recurrences, post-radiation recurrences, and so on. So, there is definitely a place, but I think there's a place for all of these treatments, and it's good to have all the skills and the facilities available.
Agreed.
I agree. Oh, Andrew, do you agree? You're a doyen of brachytherapy. That's where you went to learn your brachytherapy, wasn't it? It's fair. Yeah.
Yeah, so I did brachy for 24 years, and like Sarat mentioned, there's very, not a lot of situations, but there's situations where you can't safely treat with external beam radiotherapy. You really don't want to. Rip-roaring inflammatory bowel disease, or a guy who's had pelvic radiotherapy before. And I love it as a salvage technique after external beam radiotherapy. So it's really great to have. The issue, I've always described brachytherapy as like a 7-legged stool, right? So if any one of those things, whether it's the anesthetist team doesn't come, or you lose an expert physicist, or the nursing team isn't supportive, and it's a pretty costly program. So if you don't have strong administrative support, you can collapse a brachytherapy program really quickly. Thank God we have really good programs around the country that are high volume and sustained and supported. But it's tough for a small center. We were talking about this. Vedang was talking about they don't have brachytherapy for prostate in Tata. They have a brachy for a lot of other things. Yeah. But it's too hard to get going. And particularly with SBRT, it's
resource intensive.
Until we can show, and there's a trial going on right now that we're launching across the world, brachytherapy versus SBRT boost for high-risk prostate cancer. We call it Ascend SBRT. So we'll know in a few years how that stacks up. But in the meantime, I still consider brachy the gold standard for patients with high-risk disease.
I love it. So my take home is absolutely, as you said at the start, the hypofractionation revolution is here. Really, nobody should be getting 6 or 7 weeks. Although, one of the issues, Sarat, we consistently read is, if in your country radiation is reimbursed by fraction, it's still an issue, isn't it? I mean, that's just a administrative issue that governments need to sort that out. Because if you're going to punish your big cancer center by saying, we're going to pay you, we're not going to recognize that because you're delivering high-tech radiation in 4 weeks. And that some administrators will force it to say, is it, it's changing, is it?
That's right. So, I mean, the way around it is allocating a certain amount of fund towards treatment of prostate cancer.
And do it how you like it. Exactly. Okay, Vedang, ADT and prostate radiotherapy. So we want to talk about this in two different ways. First of all, the primary intact prostate. So again, multiple very good radiation oncology trials have shown that the addition of ADT, neoadjuvant / prolonged to prostate radiotherapy significantly improves outcomes for select patients. So we've always thought, maybe intermediate risk, we're going to get 6 months neoadjuvant, and higher risk up to 3 years, maybe 2 years now. But none of us like, suggesting to a man he's going to have ADT for a few years. And indeed, here in Australia, just a few weeks ago, there was a program on our national broadcaster focusing on the side effects of ADT. And they were telling some tragic stories, including of a patient who went on ADT for his prostate radiotherapy, but took his own life. Unbelievable situation, and obviously there's more than one thing involved here with these patients, but we all take a serious responsibility when we're prescribing ADT. So that being said, can you give us just an overview of where we are with ADT and primary prostate? We'll talk about salvage in a second.
So in general, if I have to summarize, for intermediate risk, it would be 4 to 6 months of ADT along with radiation. And for high risk, it is on an average 2 years. Okay. It can range from 18 months to 36 months, but the average 2 years is acceptable. Having said that, PACE B did not use ADT. And that, I think, getting 95%, 96% control without ADT, and many of them were intermediate risk patients, is remarkable. I think that's a big blow.
3/4 of them were actually unfavorable in that trial.
No ADT.
No ADT. And without ADT. So it's, I think, for selecting the patients, and I think what Vedang's getting at is not all intermediate risks need it. And we chatted a little bit about Artera AI. And so that this is, as these technologies come forward, help us stratify pathologic patterns that we can't recognize with a naked human eye, and be able to say, this is a person that's likely to benefit from hormones, and this is a patient that's likely not. So I think that's, I can't remember the trial, Sarat, that was open, that looked at Artera AI, but I think that's a really important
step forward. The one in New England Journal evidence, that one.
Yeah. I think it's great.
Yeah, for a high risk, the 18 to 36 months or 24 months, I think, is also, and this is a pet subject of mine. I think we are overdoing the ADT for high risk as well. Yeah. If you look at the data, the survival advantage from the trials from the 80s and the 90s produced a 10% benefit in outcomes. So, but there, the outcomes we are talking were 65 to 75%, or, approximately. Now we're talking of, for example, in high and very high risk in poverty, we're talking of 90% disease-free survival. Where do we go from there? Is ADT really needed? So I'm not talking of the node positive ones, but for the node negative ones. And we have a trial running, actually. It's a randomized trial, and it's called a RELAX.
The RELAX trial.
RELAX. So reducing the length of ADT along with external radiotherapy.
Acronyms is our secret.
Excellent.
And the design is very simple. For high risk and very high risk patients, the standard arm is 2 years of ADT. Any radiation that you like, any standard high dose, pelvis, everything. And in the test arm, we are shortening the duration to 9 months of ADT and intensifying with 6 months of ARTA, either ABI or ENZA. So intense short ADT, and we stop it for testosterone recover and hope that it works.
Well, good luck with that.
I'd just like to add a couple of things about ADT. Is one of the things is, we don't age stratify. So when we put a 75 or 78-year-old on ADT, the testosterone suppression continues for a very long time as compared to somebody in their 50s and 60s. So we probably need to think about that. And the other thing is we don't push strategies to recover from ADT or counter that enough. We don't talk enough about exercise. We don't spend enough time stressing on the importance of musculoskeletal health.
Good point. So, if we acknowledge that the therapy helps the oncological outcome, it's all predictable stuff. We just need to support the patients. But while on the one hand, I'm saying here that, probably maybe it's not a broad brush stroke. We can probably select patients a bit better, and Artera might do that trials. On the other hand, we now have Enza-Rad coming at ESMO, I think. Is it?
Yeah, that's what Chris tells me.
Yeah, Enza-Rad. So, we've been waiting for this for a few years, but another prospective randomized trial testing whether the addition of enzalutamide to ADT plus radiotherapy for high-risk prostate cancer will improve outcomes. So that's going to read out at ESMO. And then the DAZZLE HiCap study will be coming. That'll take another year or two, but same sort of idea, but intensifying the ADT by adding darolutamide. So yeah, on one hand, we're trying to stop ADT. On the other hand, we're going to intensify. But what Vedang said might be the way, Andrew, that what you want to do is intensify in a doublet for select patients. And then maybe loads of patients will just have straight radiotherapy, hypofractionation.
Yeah, I love that idea of systemic intensive, intermittent systemic intensification. I love that idea, even for metastatic disease. And I think the other thing, there's two things. One, I know this isn't available here in Australia, but there's a LHRH antagonist, an oral pill called Urologist, which seems to have a much faster T recovery. And so where we don't know, I think part of the duration of AD is the recovery. So if we give 6 months, you have to bank that there's probably 3 months extra. But like Sarat says, if there's a guy who doesn't recover, maybe if he's on 9 months of Urologist, maybe that's enough. And the other thing I think we should think about a little bit more is adding testosterone replacement.
Yeah.
Completely.
Not talking about super physiological doses, but just normal.
Get back quicker.
Like I expect this guy, and I hope this guy gets back to eugonadal status. And if he doesn't, maybe he just needs a little help.
Yeah.
You got a funny look on your face, Vedang.
A very interesting conversation I had with my dear friend Ale Berlin in PMH in Toronto. And he believes that tamoxifen helps in testosterone recovery, believe it or not, tamoxifen, and is planning a trial on that. And this will be very interesting if it works.
There's lots of raised eyebrows around the table here.
Well, we know it's good for gynecomastia, so it'd be interesting. I actually wondered whether it actually abrogates the effects of ADT. So maybe it's, anyways, more work to be done. And I think it's best done in a trial setting. I don't suggest we just start doing this willy-nilly. Don't want to be a urologist after all.
We had Alicia Morgans here in the studio last year, and exactly that she was talking about, the idea of replacing it. It seems like obvious. Why wouldn't we? If our intention is that we want that that patient's going to be on a short burst of ADT for whatever reason that will be, but if we're comfortable with the testosterone coming back up, why don't we just get the
particularly if we're comfortable with the primary treatment,
Absolutely.
if you feel radiation or
you can always come back down again.
Exactly.
So that is critical, comfortable with the primary treatment. I think what ADT was compensating was the lack of proper intensified, what is called augmented radiotherapy. Full dose, high dose, pelvic treatment,
Boost.
fractionation, boost, node, this, that. Go high up with your pelvic fields. I think ADT has a limited role if you do that.
So that's two big topics done. Who needs ADT? Line through that one, Sarat. Next one, our third topic, and then we might have time for a few quick things at the end, is metastasis-directed therapy for oligometastatic disease. Come on, we've been doing PET scanning now for well over 10 years, especially in countries like Australia and India where it's been routinely available. We keep seeing these little spots. And as the SABRE technology has developed almost in parallel to PET scanning, inevitably we've been doing SABRE to these things. I remember myself and Chris Sweeney and Bertrand Tombal wrote a paper in European Urology a few years ago talking about the Pokemet strategy. It was about that time when the Pokemets were popping up all around the place, or whack-a-mole, and of course we have trials like STOMP and we have Extend. POP-RT even comes into this, and one of the best trials that we've seen in the last 10 years in radiation oncology. But I want to just get a feel, Sarat, first of all, about how do we approach these recurrences? So patients have had surgery or radiotherapy, and a PSA is going up, PET scan is showing 2 or 3 small things, without having to resort to ADT. How does SABRE fit into all of this?
I mean, the first thing was the Phase 5 STORM trial, and then that actually directly compared pelvic SABRE or stereotactic radiation with whole pelvis radiation, and not very surprisingly, because previous retrospective studies suggested that might be the case, that the whole pelvis radiation were better. So,
did you find that surprising? No, I thought the
it's
authors...
not surprising.
Not surprising.
Because
Yeah.
we were part of a retrospective analysis
Yeah.
as well. We contributed data, and that's what kind of that showed.
Yeah. Don't just buzz the things you see. There's going to be
Yeah.
more disease.
There's going to be more disease, and I think that's the same with surgery as well. You know,
Yep.
you see one node, but when you dissect, you find more than one many times.
And then you often don't get them all. That's why pelvic lymph node dissection doesn't improve survival. But POP-RT comes into this, Vedang, as well then, of course. So do you want to just remind us a bit about POP-RT? Because that was very important in this whole conversation, I suppose, when, just as you say, you know, it's tempting to just radiate the things you can see on a nice, lovely, colourful PET scan. But Piece 5 shows us that actually, if there are nodes on a PET scan, you need to radiate the pelvis, and the outcome is better. And it's well tolerated, pelvic radiotherapy. But what about the radiotherapy for when patients don't have a visible node? I know it's a bit slightly adjacent.
When they don't have nodes, the sensitivity of the PET scan is still quite low. It's still 40%. Yeah. So if you don't see, it doesn't mean it's not there. It's still there, and you still need to treat the microscopic disease. Obviously, PSMA PET is good, but it's not that good. Yeah. So we've got to treat the pelvis, and that is proof of the pudding was there in the trial.
So what you showed in POP-RT basically was that there was a benefit in treating the pelvic lymph nodes even when the scans were negative, when they had all these high risk features.
Yes, and the important thing was giving 50 gray to the pelvis. When we looked at the patterns of failure, almost nobody failed in the pelvis with that dose. So that's an enough dose, and so that came out of the trial, and it had an impact on the distant metastasis-free survival.
And was I right in saying that pelvic radiotherapy is well tolerated? Because that's my sense, radiotherapy to the lymph nodes, as opposed to the prostate bed after a prostatectomy, where we do see morbidity.
So there is, again, a very counterintuitive thing we found in the trial, and we've looked at other literature which also reported the same. When you treat the pelvis, you would imagine that the bowel toxicity increases, but that does not happen. Nobody has shown that clearly. The GU toxicity increases, probably related to the doses that go to the bladder wall, the mid-level doses that go to the bladder wall, and that maybe ties in with what we may talk later on proton therapy. I'll leave it for that.
Andrew, anything you want to throw in about metastasis-directed therapy?
Yeah, so I think we do have a couple of small trials, and I just want to emphasize that we are doing the work, and I think that's something we have to be very proud of, like you mentioned before, because I don't think we can really move the goalposts forward or kick the ball up the field, if you will, if we don't have a solid grounding on it. So there are some other studies being done, large randomized studies. Stampede 2 is looking at this, and there's a study in Canada called PR20, which is randomizing patients to best systemic therapy, plus or minus metastasis-directed therapy for conventional imaging METs. And now we're moving those same study questions into the PSMA literature. So there's good data to support it, but it's not enough to, I think, make it standard of care across the board. But I think we're seeing some huge benefits. All of us, if we're going back to the anecdotes of the single story, one of my patients who showed up and then he relapsed after his radiation treatment, which is unbelievable in itself to believe. But then he had a single metastasis. I gave him 6 months of hormones. I zapped the MET, and he was disease-free for 12 years before it came back.
Fantastic.
Yeah, the thing with these metastatic-directed therapy and why people have moved to it even without level 1 evidence, it's so easy to do. It's so well tolerated, hardly any side effects. At almost any site, you can zap with the radiation.
And that's why at the APCC in Lugano, when the votes come up, almost everyone will say, yes, and treat the visible lesions on a PET scan. That reminds me, Andrew, I forgot when we were talking about ADT with prostate radiotherapy to talk about salvage.
Right.
So just quickly from you then, so patients who are having salvage radiotherapy to the prostate bed plus minus pelvic basin, who needs ADT along with that? Because I remember at the last APCCC, Dan Spratt had done a really good critique of this, saying we probably way overuse ADT for salvage. And of course, for us surgeons, it's very tempting just to have radiotherapy without ADT, and then you see is that PSA of 0.4 going to come down. So your take on the use of ADT with salvage?
So I think we need to personalize this. The way I do it in my practice, if I have a surgeon who's watching the patient carefully, sends them in an appropriate time when their PSA is like 0.12 or 0.14, not coming in with 1.4 or 2.0 or something like that, then radiotherapy alone to the prostate bed is very reasonable, well tolerated, and very effective. as that patient risk comes up, maybe he's got Gleason 9 cancer, maybe he's got multiple positive margins, maybe he's got a lymph node that was taken out, then I feel like I want to extend the volume of radiotherapy and I want to think about some radiation with the hormones. I like 6 months. So there's a bit of controversy from the Radicals HD study. Should we go to 24? The DAD-STOP meta-analysis just came out suggesting 6 months is enough.
Okay, I like it. Now, we've got a few more minutes. So Vedang, we're going to just quickly run through a few things. The first of which we thought about was proton therapy. So what I wrote down here in our briefing notes earlier was proton therapy. Is this dead in the water for prostate cancer? I thought that would be a quick tick. Yes, it is, but you beg to differ.
It is not quite dead. I think Particule has shown us that there is really no difference in treating the prostate alone in terms of toxicity. But the protons really come in their own. When you use image guidance, that is important. When you treat larger fields, which means you go up to treat the pelvis and you treat up to the common iliacs, even up to the para-aortic, some may argue. So when you increase the fields, we have recently had the proton therapy. We've been using it clinically for the last 2 years. We've in fact even moved to saber-like treatment with protons. So, and the dose distributions are remarkably better with proton therapy. I don't know if that will make a difference, and we are planning a trial to answer that question for high risk and node positive patients.
Okay, but it's very expensive, Andrew. What's your take on it?
So the way I look at it is, in a public healthcare system, if you're going to pay the extra dollars, I don't think the public should be paying that fare. But if you have the money and you think it's an important technology, I have no problem with people seeking it out. I just think that, the biggest bang that we have for our buck is five or 2 treatments of stereotactic radiotherapy. It's $1,500 Canadian. It's really exceptionally, exquisitely cost effective.
And that's one of the things in the randomized trial. One of the things we discussed this on the podcast. It's reassuring how good the outcomes are with just standard modern radiation. So it's become a much higher bar that protons have to compete with. But Sarat, here in Australia, as we speak, there's no proton centre running. The government in South Australia are nearly going broke trying to put one in. I was down there during the week and they've got this huge bunker built, but the company they're trying to buy it off in the US, I understand, has gone broke. So that's, that's the way it is down there. Here in Victoria, I think we have a project ongoing and we're all learning lessons from that. And these smaller gantry machines will be a lot less expensive. But I understand that the current proposal for putting one here in Melbourne is that we won't be doing prostates on it. We'll be doing other stuff. So clearly there's benefits for other stuff, but can it run without prostates and without breast, I suppose?
I guess if we have one proton machine in the whole of Australia, we need to use it for pediatrics, and sarcomas and choromas.
You can send them over. You can send them over to Mumbai with business class flights. It'll still be cheaper, I think. And I'll throw in the sightseeing for free.
There you go.
Okay, I love it. 2 more quick things then, if you don't mind, before we head out to dinner. Sarat, I want to give you an example. This comes up in our MDT, I'm afraid, all the time. The fit young patient, let's say it's a 55-year-old colleague. He's got, Gleason 9 prostate cancer and he's at a PET scan. He's got 2 or 3 little lymph nodes. One might be an obvious one in the external iliac, but one is presacral. Another one might be mesorectal. So these are nodes that are not in the classic template. One of the reasons why extended pelvic lymph node dissection doesn't improve survival. But in recent times, we've been tempted to do a prostatectomy but leave the lymph nodes, knowing that pelvic lymph node dissection doesn't improve survival. And we hear from our radiation oncology colleagues that, we're going to treat the pelvis with radiotherapy and it's more straightforward and less complications if you surgeons haven't done an inadequate pelvic lymph node dissection. So this is no evidence on this, but it comes up in MDTs. It's kind of a classic APCCC scenario. And it'd be lovely to have a trial to do it, but really good local control with a high quality prostatectomy, but don't go near the lymph nodes and just have a classic multimodal approach up front. We're planning to irradiate the pelvic basin. Is that crazy?
You're saving almost nothing for the patient, really, because why would you do surgery on the prostate? Local control with radiation, with SBRT or non-SBRT or with HDR boost is equally good. I don't see why there was a need for surgery in such a patient. You're not reducing any risks for them as well.
But some patients do have really bad LUTs. Declan, before treatment, we have these guys with massive prostates and big median in the lobes
Yes.
that. So you're going to TURP that patient. Sometimes it's better to get a big bulky gland out. So I'm not saying, I wouldn't say no to all for surgery, but I agree for the typical patient who's coming in with decent sized gland, decent urinary function, we can do SBRT to the pelvis and prostate, 5 treatments, totally non-invasively, and do a good job.
Look, I mean, if you're doing surgery for this, and there are a couple of nodes, I would say go ahead and do the dissection. The radiotherapy is going to be needed in any case. I mean, that's going to be node positive, and with adjuvant radiation with high Capra score, I think the patient will need radiation in any case after that. So
it's sometimes because the nodes are really in pretty much
difficult
inaccessible
places.
places, that are not in the template. And again, raises up, well, why would you do surgery at all? But I'm just putting it out there. That sometimes, sometimes the patient, I really want a surgery. My brother had a prostatectomy. It was fantastic. I want this thing out of me, and maybe I have some symptoms, but I'm just saying it comes up in MDTs, right? So it's a thing.
Yeah, I mean, if those are the reasons, like patient desire or urinary problems, then certainly.
Finally, future gazing technologies. That's the last thing we wanted to talk about is to consider, okay, you three have all been at the forefront of these technologies emerging over the past 15 years. So Sarat, I might ask you, first of all, can you think of a technology that you're excited about coming through? I don't know whether it's MR, LINAC, or some sort of AI enhanced modeling, or a technology indeed that isn't on the horizon, but you'd love to see that would really help you looking after your patients.
First up, I would like an auto contouring tool that's very effective. I think that's the greatest immediate need, because as we do these complicated treatments, the amount of time we spend on contouring it's increased. And if you're talking about Pokemon treatments, each Pokemon we have to spend a few hours, if not contouring all the normal stuff. So that's the first off the block that would be good to have, and shouldn't be very difficult.
It's available now.
Available now. So
Just got to buy it.
Yeah.
And other things like image enhancement for IGRT. We do have onboard imaging on the machine, but sometimes that can be hazy and not. You would all read about the cat in the snow blizzard and how AI can make the cat visible. So similarly, a prostate or a bowel or whatever can be very visible.
Surely. Vedang, I'll pass it over to you.
Well, in addition to the auto contouring, I mean, I have a lot of residents, so that becomes easier
That's his
for me.
auto contouring.
Those are my auto contouring tools. Jokes apart, I think we've been talking about biomarkers and better selection for, decades, since I was a first year resident, nothing has happened. I mean, we talk of Decipher, but it's not available. And we now talking of Artera, and it's still limited availability. So I really think that is the key. We need to know who needs ADT. We need to know who needs a high dose. We need to know who needs radiation itself. I think if that doesn't happen, we're not going to move very fast, very much. I think that's
surely we will. Yeah. A more personalized approach.
Yes.
Andrew.
I'll add 2 more things to that. I agree with both of those suggestions. Actually, Ali Berlin and I were talking about this. You can actually take a CT scan done for diagnostic purposes, upload that into a machine, and come up with a radiotherapy plan ahead of time. So imagine going into your consultation with the Uradonc, and he's already figured out what your quality of life is going to be like, and you can choose which treatment program you want before he actually measures you. And the second thing is, getting back to what we talked about before, better precision is better treatment. And so the technology, whether it's seeing things better, cats in the snowstorm, or whether it's real-time motion management, and whether that's an MR Linac or just these machines. For example, Varian has a machine called Ethos, which gives us hypersight, which gives us diagnostic imaging quality images. And so with that, we can do adaptive radiotherapy, link it up with AI, and I think we'll be able to really move the needle even further. The issue is we're really getting to 99% cure rates for intermediate risk patients. And so it's really about making that quality of life better. And I think higher precision radiotherapy and surgery is the way to do that.
I love it. What a fantastic podcast. Me and these 3 horsemen of the apocalypse, as they've described themselves. But it's been very, very enjoyable. Sarat, thanks for sitting in as the co-host on the podcast. I think Renu would be very impressed.
I hope she will be.
You'll be back for more. Vedang and Andrew, thanks so much for being around, being in Australia this week and sharing your immense expertise with the team at Peter Mac today, with our audience and with the Frog audience later in the week. So that's all we have time for on this episode of GUcast. I hope you enjoyed it. This episode is supported by our partners at Icon Cancer Centre, who support us through an educational grant. So thanks very much again, everyone, and we'll be back soon with another episode of GUcast. Thank you.